Welcome to Part 2 of our acute renal failure deep dive. In Part 1, we established the framework to localize acute kidney injury. Here, we delve deeper into the specific etiologies, prerenal, intrinsic, and postrenal, and the diagnostic clues that separate them, followed by disease-specific management strategies. Let's begin with the etiologies and diagnosis of acute kidney injury. We will work through the three core buckets, identifying the specific causes and the fingerprints each one leaves in the blood and urine. Master these, and you can localize almost any case at the bedside. Prerenal etiologies stem from three main issues: a drop in effective arterial volume, such as hemorrhage or sepsis, the use of hemodynamic drugs like NSAIDs or ACE inhibitors, or large vessel problems, such as renal artery stenosis. Each results in reduced renal perfusion. Why do drugs matter? The glomerulus uses two arterioles to maintain filtration pressure. Prostaglandins dilate the afferent arteriole, while angiotensin II constricts the efferent. NSAIDs block prostaglandins, and ACE inhibitors block angiotensin II. Alone, they are often tolerated, but combined, they can cause filtration to collapse. In prerenal disease, the kidney is healthy but hoarding. You'll see a bland urine sediment, a FeNA under 1%, and a BUN to creatinine ratio over 20:1. If the patient is on diuretics, the FeNA is unreliable. Switch to the fractional excretion of urea, or FEUN, which remains accurate. Intrinsic injury implies damage to the kidney tissue itself. We localize this to one of four compartments: the tubules, the interstitium, the blood vessels, or the glomeruli. Each has distinct causes and a unique urine fingerprint. Acute tubular necrosis, or ATN, is the most common intrinsic cause. It is driven by ischemia, such as severe prerenal states or sepsis, and by direct nephrotoxicity from drugs like vancomycin, aminoglycosides, or cisplatin. Always review the medication list when creatinine climbs. Beyond medications, ATN can be caused by pigments like myoglobin or hemoglobin, monoclonal proteins such as those seen in multiple myeloma, and crystals. Crystals can form from tumor lysis or drugs like acyclovir and methotrexate. Identify these triggers to prevent further injury. The laboratory signature of ATN is often the muddy brown, pigmented granular cast. Because the tubules are damaged, sodium wasting occurs, raising the FeNA above 2% and lowering the BUN to creatinine ratio. Remember, pigment and contrast-induced injury are exceptions where the FeNA may remain low. Acute interstitial nephritis, or AIN, is inflammation around the tubules. Triggers include allergic drug reactions, infections, infiltrative diseases like sarcoidosis, and autoimmune conditions like lupus. Recognizing these triggers is essential for intervention. Diagnosing AIN involves looking for white blood cells and white cell casts in the urine, often with sterile pyuria. While the classic triad of fever, rash, and eosinophilia exists, it's frequently absent. The most vital management step is removing the offending drug. Corticosteroids may be considered early on. Other intrinsic categories include small and medium vessel diseases, like cholesterol emboli or thrombotic microangiopathies, and glomerulonephritis. Glomerulonephritis is inflammation of the filter itself, characterized by dysmorphic red cells and red cell casts. These require specific diagnostic workups. Postrenal failure occurs when urine outflow is blocked. Causes range from bladder neck obstruction by BPH, to bilateral ureteral issues, to urethral blockages. Diagnosis involves imaging, where ultrasound typically reveals hydronephrosis. Be prepared for a significant post-obstructive diuresis once the obstruction is relieved. Now we will shift focus to disease-specific management. Each of these highlighted conditions requires a specific playbook. Understanding the mechanism and identifying the diagnostic clues will change the clinical outcome for your patients. For acute interstitial nephritis, management centers on stopping the offending agent. If an immune checkpoint inhibitor is the cause, the decision to rechallenge depends on the oncological context. Balancing renal risk with cancer treatment benefits is a key discussion to have with the oncology team. Next, let's look at cardiorenal syndrome, where the heart and kidney compromise each other. The mechanism is a downward spiral involving low cardiac output, renal venous congestion, and RAAS activation. It is a bidirectional process, where heart failure worsens kidney function, and vice versa. Management of cardiorenal syndrome focuses on intravenous loop diuretics to bypass gut edema. Evidence shows no clear advantage for high versus low dosing, or bolus versus continuous infusion. Furthermore, dopamine, nesiritide, and ultrafiltration have not been shown to provide significant clinical benefit. Contrast-induced acute kidney injury is a concern after imaging with iodinated dye. Risk factors include pre-existing kidney disease, diabetes, heart failure, and older age. Creatinine typically rises within 48 hours and peaks within 5 days. Prevention relies on isotonic hydration and minimizing the contrast load. When dealing with contrast-induced injury, you should pause medications like ACE inhibitors, ARBs, and NSAIDs. Additionally, choosing an isoosmolar contrast agent may help reduce the risk in vulnerable patients. Nephrogenic systemic fibrosis is a rare but serious condition linked to certain gadolinium-based contrast agents used in MRI. It manifests as fibrosis of the skin, joints, and internal organs in patients with advanced kidney disease. Fortunately, modern Class II agents carry minimal risk. Hepatorenal syndrome is a functional renal failure occurring in advanced liver disease, where the kidneys remain structurally intact but suffer from reduced perfusion. Terlipressin, often paired with albumin, is the standard therapy. Monitor closely for signs of ischemia, as this medication causes systemic vasoconstriction. Obstructive uropathy requires prompt decompression. Use a Foley catheter for bladder-level blocks or a percutaneous nephrostomy for higher obstructions. Once relieved, be prepared for post-obstructive diuresis and manage it by carefully replacing fluid losses to prevent hypovolemia. Polycystic kidney disease is an inherited disorder characterized by cysts that replace healthy tissue. While PKD1 mutations generally lead to earlier kidney failure, management focuses on long-term preservation of GFR through hydration and, in specific cases, medication like tolvaptan to slow cyst progression. Rhabdomyolysis causes injury through myoglobin release. Look for heme-positive urine without red blood cells. Aggressive fluid resuscitation is the cornerstone of treatment to keep the kidneys flushed. Keep a close watch on electrolytes like potassium, calcium, and phosphate, as these can shift dangerously. Scleroderma renal crisis is a medical emergency presenting with severe hypertension and acute kidney injury. Paradoxically, the most effective treatment is the aggressive use of ACE inhibitors. Do not hold these agents, as they are crucial for protecting renal function in this specific crisis. Finally, COVID-19-associated AKI is frequently driven by acute tubular necrosis, though collapsing glomerulopathy is also possible. Watch for an increased tendency toward clotting, which can impact the patency of dialysis circuits if renal replacement therapy is required. Support the kidneys while managing systemic inflammation.